So question 1, what esophageal diameter what is the esophageal diameter one would eventually want to achieve as a goal when dilating adult patients with benign esophageal strictures? So please choose your answer in the poll box. You can choose 14 millimeters, 16 millimeters, 18, 20 millimeters, or other. You should be able to vote in the poll box. Can you try voting for me? So, Mikhail, so far I'm seeing no answers. So I'm wondering if we're not picking up the responses. I'm not getting any responses. Oh, I see. People have to submit all 5 at once. Okay, so we'll move on to question 2. Question 2 is a 48-year-old patient with radiation-induced 3-centimeter esophageal stricture. The radiation was for squamous cell cancer of the esophagus. Is referred from another hospital after having undergone 8 endoscopic dilation procedures with steroid injections over a 4-month period with minimal response. What would you consider doing next besides repeating biopsies? Continue dilations, trial of esophageal stenting, electrocautery incision, trial with oral steroids, or gastrostomy tube? So please record your answer on the poll under question 2. Then we'll go on to question 3. And I'm showing you the PowerPoint so you can read the entire question, which doesn't fit in the poll box. So question 3, despite being compliant with taking her proton pump inhibitors in the right manner, a 68-year-old patient with congestive heart failure and GERD-related gastroesophageal junction stricture is not responding to dilations. What could be the reason? And the choices are the PPIs are not working, there's a pill injury, food stasis injury, motility disorder, or adenocarcinoma. So record your answer for question 3. Question 4, an esophageal stent was placed and then removed after 4 weeks for a 4-centimeter long corrosive-induced esophageal stricture. The esophageal lumen looked wide and open to 18 millimeters when the stent was removed. How will you follow up this patient? Endoscopy after 1 week, after 2 weeks, after 12 weeks, after 6 months, or as needed? So record your answer in the poll box, and then we'll move on to question 5. A patient who has received chemotherapy and radiation for head and neck cancer developed a tight pharyngeoesophageal stricture. He also failed an oropharyngeal swallow study with significant laryngeal penetration and some aspiration. He's on G-tube feeding but wants to eat for quality of life. Would you consider dilating this patient in the background of unsafe swallowing? No or yes? So record your answers in to question 5 and then submit responses, please. There should be a blue submit button in the lower right corner. So far I only have 3. So please record your responses to the poll questions. And when you're done, there's a submit button you have to click at the bottom right corner. Now their answers are coming. Kulwinder, would you like me to go through all the responses or one at a time as you discuss the cases? I'm sorry,
sorry, I was muted. If you want me to go through my talk and then you know, I mean, these questions are, there's no one right answer, and obviously that's the reason for the talk. Do you want to show me the answers, or should we take the poll again at the end of the talk?
Well, let's just go through so you can see. So question one, can you see them there, the responses?
No,
it
I
looks
can,
like
I can only see,
choice with,
I can only see your screen.
okay, maybe I need to end. All right, so shall I end the poll then? Okay, well, I think if I end the poll, you'll be able to see the responses. How about now? Stop share. How about now? Can you see them?
I can see them, yeah.
All right, so question one, the most popular choice was 18 millimeters. Question two, the patient with prior squamous cell cancer treated with radiation, who was required multiple dilations. The most popular choice was trial of esophageal stenting. Question three, despite the woman with a refractory gastroesophageal junction stricture, the most popular choices were either the PPIs were not working or she has an adenocarcinoma. Question four, the patient who has had the esophageal stent removed, the most popular answer was to do an endoscopy after 12 weeks, or else others said as needed. And the last question, patient who had prior chemo and radiation for a really oropharyngeal to esophagus stricture, most said they would go ahead with dilation even though the patient failed the swallowing study. But there was a mixed opinion. So it was very interesting. Obviously, we have some controversy about these cases, Professor. So it'll be very interesting to hear your lecture. So I think now I need to be able to have you make you a co-host so that you can share. Let me do that. Okay. Okay, you should be able to share your screen now, and we'd love to hear your presentation.
So let me share my screen and all right, for whatever reason, the sharing window has stopped. Let me share it again.
Are you able to share your screen? We can just you can share your screen and advance your own slides as you go. So there's a button below the images at the bottom of the Zoom window. It should say share screen in green.
Yes, I'm trying to do that. Somehow it stopped my PowerPoint. Let me just
try opening it again.
Yeah, that's what I'm trying to do. Yeah.
There you go. It says you have started screen sharing.
Could you see? Can you see the first slide? Thank you, Haley, and thank you, Mark, for inviting
yes, there we go. I can
see. I am Kulvinder Dua from
see
the
it.
Medical
Now,
College.
Can you put it on slideshow mode?
And I will be talking on endoscopic management of refractory. I have the following disclosures. None of these products will be discussed in my talk. Esophageal strictures can be located anywhere from the pharyngoesophageal segment to the gastroesophageal segment. They can be benign or malignant in etiology. Can you hear it?
Prof, can you use the slideshow?
All right, let me. Can you see it now?
And thank you, Mark, for inviting me to speak at this session. I am Kulvinder
I'm
Dua
hoping you
from the
can
Medical
use
College
the
of Wisconsin,
slideshow
Milwaukee,
feature so
USA,
that
and
the
I will
images
be
are
talking
larger.
on
Right now we're
endoscopic
seeing the
management of
presenter view.
refractory benign.
Can
Okay,
you try the slideshow view?
All right. I did that for whatever reason. It's not doing it, but let me do this again. Then I'll.
Is the audio pre-recorded?
Yeah, audio speed record. Can you now? I had two screens. So
Yes, we can see this. We can see now the view where you are able to sort and edit the slides. Usually there's a
now can you see the full view?
option.
And thank you,
That's
Mark, for
better.
inviting me
Yes,
to
we
speak
can
at
see it
this
nicely.
session.
Can
I
you
am
hear me?
Kulvinder
Yeah,
Dua
but
from
we're
the
also
Medical College
hearing.
of Wisconsin.
Yes, but we're also hearing a
USA,
recording of
and
your
I will be
voice.
talking on endoscopic
Can you turn
management
that
of
off?
refractory benign esophageal strictures. What's new? I have the following disclosures. None of these products will be discussed in my talk. Esophageal strictures can be located anywhere from the pharyngoesophageal segment to the gastroesophageal segment. They can be benign or malignant in etiology, or sometimes we don't know what's going on when we call them the indeterminate strictures. Based on their configuration, they can be simple strictures or complex strictures. Simple strictures are generally short, less than 2 centimeters in length, straight, and a standard 9.5 millimeter diameter endoscope can pass through them. Generally, with 1 to 3 dilations, we get good response. These are generally caused by acid reflux, webs, rings, and so on. In this talk, I'll be focusing on complex benign strictures, especially those located at the pharyngoesophageal segment, which are the most difficult to treat. Complex esophageal strictures are generally long, they can be tortuous and multifocal, and frequently a standard or even a thin endoscope cannot be passed through them. They are usually caused by corrosive radiation or pill injuries, can be post-surgical or injuries related to mucosal resection and dissection or photodynamic therapy. Let me start off with this patient who was referred to us as having a refractory benign esophageal stricture thought to be peptic in origin, a 78-year-old female with congestive heart failure on proton pump inhibitors and had undergone 15 dilations over an 11-month period. When she was admitted, a medical student on taking her history found out that she was on potassium pills, and when the offending agent was withdrawn, her mucositis settled and the patient just required 2 more dilations to address her stricture. It's important, therefore, to get a good history, and peptic strictures with good proton pump inhibitors available in the market generally should not be refractory. There could be superimposed pill injury, food stasis causing mucositis, and also one would wonder whether the proton pump inhibitors are really working if they're getting stuck at the level of the stricture. Pardon me for throwing in this basic slide over here. As you'll see, we grade our dysphagia from grade 0, which is normal swallowing, to grade 4 when you are literally drowning in your own saliva. For normal swallowing, we need to have an esophageal lumen that is 14 millimeters or more, and hence when we dilate these patients, we tend to go up to about 16, 18, or even 20 millimeters. Talking about dilation, endoscopic dilation with or without steroid injection should be the first line of approach in managing patients with benign esophageal strictures presenting with dysphagia. There are two kinds of dilator. The bougie that goes outside the scope can be advanced over a guide wire. This exerts longitudinal and radial forces on the stricture, while the balloon that can be passed through the accessory channel of your scope will exert pure radial force. In expert hands, both of them have been found to be safe. However, I have one recommendation to make, and that is when we use a standard 9.5 millimeter scope and we are evaluating the stricture, we may come across a very tight region as shown over here, and we tend to use the balloon, not realizing that there's another area that will allow the scope to go through but is less than 14 millimeters in diameter, and this can give the patient ongoing dysphagia. Hence, if we suspect patient having multifocal strictures as we see with radiation or corrosive injuries, then I tend to use the bougie, which not only helps me in palpating the resistance of the stricture, but also causes pan dilation of the esophagus from the upper sphincter down to the lower esophageal sphincter, addressing all areas that I may have missed with the standard endoscope. Although there are several studies that have shown that injecting steroids into the stricture after dilation can reduce fibrosis, however, unfortunately, despite this, the recurrence rate can be as high as 45%. Using concepts from the cardiology literature, recently Wang and his group from the Mayo Clinic presented their data at the last DDW, where they used paclitaxel coated dilation balloons for esophageal strictures and showed promising results. However, majority of their patients had peptic strictures, and hence these results cannot be extrapolated to true refractory benign esophageal strictures such as those occurring from corrosive injuries or radiation injuries. Moreover, it was a short follow-up and the study was not randomized. So what is a refractory benign esophageal stricture? It's a fibrotic anatomic restriction where one cannot achieve a diameter of 14 millimeters or more despite 5 sessions of dilations done at 2-week intervals. Or if one does reach that diameter, it cannot be maintained and the patient requires at least one dilation every 4 weeks. Having said that, it is not essential that we achieve a diameter of 14 millimeters in all patients and risk perforation. For example, in this particular patient with a very tight stricture of 2 millimeters in diameter, we used a balloon and dilated the stricture to 8 millimeters. Using the area of the circumference formula of pi r square, we increased the area from 3.14 to 50.24, which is a 16-fold increase in the area of the circumference that led to this patient taking all liquids and some soft diet, which improved the quality of this patient quite a bit, and therefore we did not push it to 14 millimeters and risk perforation. Patients with head and neck cancer pose a unique problem because they have radiation strictures or post-surgical strictures that are located high up at the pharyngoesophageal segment and have associated swallowing disorders, which I call as a compromised pump besides a blocked pipe. These are fibrotic strictures that cannot be reversed, and unfortunately, perforation in this area can be very unforgiving because surgery can be very challenging. I know many of my colleagues are reluctant to dilate patients referred to us by our SLP colleagues with defective swallowing mechanisms because the benefits may not be the greatest while we risk perforation. However, I tend to accept these patients because, as shown in cardiology literature, whenever the peripheral vascular resistance is reduced, even with a weak heart, you can increase the cardiac output. Hence, if you have a weak pump, which is also leaking material out from the nasal cavity, if you dilate the stricture and decrease the afterload and make this the path of least resistance, the output may increase and we will also reduce the likelihood of nasal regurgitation. As an example, this patient was referred to us by a speech language pathologist. The patient had a pharyngoesophageal stricture and an oropharyngeal swallow study showed reduced lingual force and a reduced velopharyngeal closure with retropulsion of liquid material into the nasal cavity and coming out through the nose. We went on a dilation protocol on this patient, and 2 months later, the patient continued to have reduced lingual force, continued to have reduced velopharyngeal closure, but this time, because the stricture was dilated and material was going through the path of least resistance into the esophagus, there was no nasal regurgitation. This again brings in the importance of approaching these patients in a multidisciplinary manner. And from our speech language pathologist, we do get a lot of guidance whether we should continue dilating these patients or stop, especially if the swallowing is unsafe. We at times encounter patients where the pharyngoesophageal segment is completely occluded. Over here, our ENT faculty passes a scope from the top end. We take a thin scope and through the G-tube site climb up retrogradely to this level, look at each other's light, puncture the septum, pass a guide wire, and embark on a dilation protocol. Another area where we coordinate is when the patient has a voice prosthesis because we don't want it to fall into the airways during dilation. In these situations, our ENT colleagues take the voice prosthesis out in the room, we dilate the patient, and they put it back in. Hence, our goal during dilation should be to achieve a luminal diameter enough to improve the quality of life of that particular patient and to maintain this diameter with minimal reinterventions. The second issue I have with this definition is this dilations done every 2 weeks. When we dilate a stricture and bring the patient back in 2 weeks for repeat dilation, we expect to go 2 steps forward and 1 step back. What if we go 2 steps forward and 2 steps back when we dilate them every 2 weeks? Although several of these patients are referred to us as having failed dilation, guess what? The first line of approach we use in these patients, so-called the Medical College of Wisconsin protocol, is to dilate them. Instead of dilating them every 2 weeks, we dilate them every week, sometimes every 5 days. And at each subsequent dilation, we evaluate how much the esophageal lumen has regressed, based on which we space out the intervals between dilation until we reach a point where the patient requires not more than one dilation every 3 to 4 months. At that point, we tell the patient to call us as needed. In case this protocol is not working, then we apply additional interventions. So let's discuss this patient, 66-year-old female with squamous cell cancer of the larynx, status post-chemo radiation, who developed a tight pharyngoesophageal segment stricture resulting in recurrent aspiration pneumonias despite undergoing several dilations around 14 to 20 per year. She was referred to the Medical College of Wisconsin where elective laryngectomy was performed and we started doing weekly dilations with steroid injections, but this also failed. So what did we do? When we dilate a stricture, say with a balloon, we inflate the balloon for 2 minutes and we hope that that will give a few weeks of relief. What about inflating the balloon for about 17,000 minutes round the clock? Will that give long-term relief and how can we do that? The way we do that is we place esophageal stents that not only allows the patient to eat but also acts like a dilator sitting there around the clock, and anywhere from 1 month to 3 months later we take it out and we hope that that will give long-term relief. Only fully covered expandable stents can be used for benign indications since these stents will prevent tissue ingrowth and hence they can be removed after a particular duration of time, which nobody knows, can be 1 month or after 3 months. Initial experience on using stents for benign esophageal strictures coming out from Europe showed very promising results with 80% success rate and 6% complication rate. Subsequently, studies from USA showed exactly the opposite with 6% success rate and over 80% complication rates. We did the first prospective non-randomized study on a large series of patients and found that the pendulum was somewhere in between, with around 40% of these patients responding to the stent. And although there was a complication rate of around 28%, majority of these were migration of the stent that could be easily addressed by removing the stent. I must point out over here that the only stents available in the US for benign esophageal strictures are the self-expanding, fully covered plastic stents that are not much used because they have several shortcomings as described over here. They are not preloaded, the delivery system diameter is too large, they can have erratic deployment, cause significant chest pain, and there is a high migration rate. So most commonly, we are using fully covered expandable metal stents that are not yet approved for benign indications and hence we have to use them off label. This is exactly what we did in this patient. This is the tongue, hypopharyngeal region, and this is the delivery system of the stent that we are deploying across this area. The question that comes up frequently is that will the patient tolerate a stent sitting in the pharyngoesophageal segment? The answer is yes, because this area with the radiation and surgery could have a dampened gag reflex. And in this particular patient who had an abscess destroyed the hypopharynx and the upper esophagus, we placed a stent right at the arytenoid level for 4.5 years to regrow this area using regenerative medicine techniques. Others have used modified stents where the pharyngeal part is smaller and shorter in diameter compared to the esophageal part, and people can also use the Montgomery tube in extreme situations. In our patient, we removed the stent after 8 weeks. We sent her back to the weekly dilation protocol, and over a period of time, she responded very well. And currently, she is now 83 years of age and only calls us if she needs us. Biodegradable stents are available in Europe where the stents get metabolized by our carbohydrate cycle and therefore we don't have to remove them. There are several studies looking at the outcomes of using biodegradable stents for benign esophageal strictures coming out from Europe since this stent is not yet approved in the USA. I'm just quoting one of the initial studies that showed at 1 year follow-up, 46% of the patients remained dysphagia-free even after the stent had biodegraded. What if the pharyngoesophageal stricture is very fibrotic and it is like trying to dilate concrete? In these situations, we can cut the stricture endoscopically using an electrocautery needle knife as shown in this video clip. We cut pretty deep so that all the fibrotic tissue can tear open, and even though there could be microperforation, I generally try to place a stent immediately after needle knifing so that not only the stent will seal any microperforation, but it will also tear open the area more, following which we remove the stent in about 4 weeks. There are many studies looking at the outcomes of using electrocautery, and in this one particular study shown over here, where all types of strictures, including those at the pharyngoesophageal segments, were included, the success rate was 100% when the stricture was short, while a mean of 3 sessions were required for longer strictures. Now, this is an important slide. Many people use other interventions and then get laid back, hoping that the patient will continue to eat. However, what we do is that after we apply other interventions, we make sure that the patient then goes back to the weekly dilations and then continue on as described earlier. We formally studied our protocol in 2 groups of patients. Group A included patients who were referred to us from outside hospitals after having failed dilation attempts. Using our protocol, we were successful in 55% of these patients in addressing their strictures, and amongst this successful group, in around 55% of these, only dilations were required to address the strictures, while additional intervention was required in around 45% of these patients. Because our protocol was succeeding, we had more and more patients now being referred to us without any prior interventions directly to use our protocol upfront. We call them the group B, and in this group, the success rate was significantly higher compared to group A when we applied the protocol upfront, and in them, in only 17% of patients, we required additional interventions. Now let's see what happens to patients who fail our protocol. This is a 55-year-old male with supraglottic squamous cell cancer who completed radiotherapy, was having chronic aspiration that then led to total laryngectomy. Patient had a very tight hypopharyngeal esophageal stricture requiring one dilation every 3 to 4 weeks going on for almost 2 years, became G-tube dependent and then was referred to us. We applied our weekly dilation protocol, but again failed.
Hello, good morning. How are you doing?
I'm doing just fine.
And thank you for giving us permission to record you.
You're welcome.
How long have you been dilating yourself?
About 3 years,
And you dilate how many times a day?
4 times a day.
And what dilator size you use?
I use a 36 and a 38.
The concept of self-dilation is not new. Way back in 1961, the first case was reported, following which another 3 cases were reported the same year. In 1984, 13 patients with a total of 4,600 home dilations were reported, and in the recent past, 16 patients who dilated themselves anywhere from 15 millimeters to 20 millimeters were reported. And guess what? In none of these patients, any perforation was encountered. We now here at the Medical College of Wisconsin run a self-dilation clinic primarily staffed by a speech-language pathologist. I do not have time to go into the details on how we train our patients, but it is something that one should learn how to do, because this is a very important part of our armamentarium in managing these complex patients. As you will see, ASHA covers esophageal self-dilation to be within the SLP's scope of practice, and there's also a billing code for it. I would like to wrap up my talk by showing some slides on some new concepts that are coming out that are not yet ready for prime time. Whenever we dilate a stricture or remove a stent or use electrocautery, we cause significant mucosal damage that then heals with stricturing. Hence, we keep going in circles. We focus on the dilation part, we cause mucosal trauma, and then this causes the stricture to come back. So the new focus now is to see if we can immediately restore the mucosal barrier after mucosal injury during endotherapy. Now, why does this happen? Looking at the literature on wound healing, whenever the epithelial barrier is broken, fibrosis sets in 2 weeks, and the centripetal movement of the epithelial layer takes around 5 weeks. As seen over here, the epithelial barrier is still broken, but fibrosis has already set in, and by 5 weeks, when the epithelium grows back, the lumen is already distorted by fibrosis. So one of the strategies that can be used is that after dilating the patient and causing mucosal trauma, we can hasten epithelialization before fibrosis sets in. Using principles of regenerative medicine to hasten epithelialization, one can inject autologous pluripotent cells to the site of mucosal injury, or grow these pluripotent cells into cell sheets and apply it at the time of injury, or use autologous skin grafts wrapped around a stent and placed across the stricture. For example, in this study done on 9 patients with superficial esophageal cancer, autologous buccal mucosal cells were grown into cell sheets around 10 days prior to circumferential endoscopic submucosal dissection, and on the day of the dissection, these cell sheets were applied to the raw surface. It is not important that the whole area should be covered because they grow and interconnect with each other within a few days. Only one of the 9 patients developed a stricture, when otherwise we would have expected all of them to have an esophageal stricture. Since regenerative medicine technology is expertise driven and not readily available in many centers, in one particular study, a center was identified over 1,200 kilometers away. Patients' buccal mucosal cells were couriered to that center around 2 weeks prior to mucosal resection. The cell sheets were grown and couriered back and successfully engrafted in all patients. Others have used synthetic collagen material or commercially available extracellular matrices to prevent stricture formation. So in summary, we recommend as the first line of approach to do weekly step-up dilations with or without steroid injections till we reach a luminal diameter that can maintain a reasonable quality of life for the patient we are treating. Do not try to overachieve and risk perforation. Based on the response, then we increase the intervals between the dilations till we can achieve what we call a success, meaning none to a maximum of 1 dilation every 3 months. So having 3 to 4 dilations per year is not bad. If we do not succeed, then we use additional measures like electrocautery needle knife incisions or expandable metal stents. And after this, we go back to weekly dilations. Anywhere along this path, we offer our patient the training for self-dilation if the patient is interested. Recently, regenerative medicine principles are being applied to restore the mucosal barrier that is damaged immediately after endotherapy so that the recurrence of strictures can be delayed. This is not yet ready for prime time. As you may have realized from my talk, most of my discussions and approach have been anecdotal and case series. There are unfortunately very few head-on comparative prospective randomized studies comparing various techniques, and at the current time, no firm recommendations can be made on which technique is better than the other. Thank you.
Rob, thank you very much for that outstanding lecture, and I'm sure we're going to have some good discussion. So would you please post your questions in the chat and let us know what questions you would like to ask Professor Dua. And while I'm waiting here, okay, thank you. We have a question already, Prof. Thank you for your talk. Please expand on the use of steroids again. What are the role of steroid injections and how do you yourself do steroid injections?
Yeah, well, again, thank you, Haley, and thank you, Mark, for inviting me. I had pre-recorded my talk just in case my internet fails or, I can't project my talk. That's the reason I recorded it, and I was going to email it to you all, in case things don't work out. Anyway, the thing about steroids is that the data is quite mixed. Those meta-analysis that I showed have shown promising results. When you inject steroid in that one meta-analysis of over 200 patients, those who did not get steroids, the recurrence rate was 77%, but those who got steroids, the recurrence rate was 45%. For me, that's good. P-value was significant, but 45% recurrence is also not acceptable. And that's the reason, when we try steroids, we try it hoping it may be one of those patients who may respond compared to those who don't. The good thing about steroid injection is that it's not at all a difficult thing to do. There's a little bit of cost involved. You have your sclerotherapy needle, you need your triamcinolone that you inject in 4 quadrants. I like to inject it after I dilate, after the mucosa has been sheared so that I can inject it into the submucosal area or the fibrotic region. And you inject it with a sclero needle. The problem that I have had, I can only anecdotally speak that I have had at least 3 patients who developed a fistula. And I don't know whether that was because it was just coincidental or that every time we dilate a patient, we probably microperforate and the fibrosis closes it off. And now you're delaying fibrosis. Will that lead to fistula formation? So those 3 cases that I had who developed fistula, I'm not sure whether our needle went through and through, we made a hole and we prevented fibrosis. My recommendations are that it is so easy to apply and it is something that can be done So it is worth a try. There are, I know, even balloons available which are coated with steroids, and they can be, I was actually one of the investigators for a balloon from a company that had steroid coated on it. We didn't see much of a difference. And last but not the least, people have given oral steroids, which is even like thought to be easier than injecting and risking all that everything else that comes with the sclero needle going through the wall. And oral steroid, if you look at the studies, have also shown promising results. Unfortunately, the studies that have not shown promising results never get published. Talking to Peter Dragonoff the other day, we were discussing in one of our talks about giving like we give for eosinophilic esophagitis. After we dilate them, can we give them fluconazole to swish and swallow? That will coat the lining and prevent fibrosis. All these are like trials. Nobody knows any long-term outcomes. So long and short, worth a try, easy to do, and therefore go ahead and see if it works.
That leads to another question Lars Abikin has asked, which is very relevant to practice in sub-Saharan Africa. We have a lot of caustic ingestion strictures in many of our practices, often in children, long and difficult strictures. And Lars asks, any role for surface mitomycin application for fibrosis mitigation? I think a lot of the literature on mitomycin actually comes from sub-Saharan Africa. But what's your view on mitomycin, and if you do use it, how do you apply it, or do you inject it, or how's that drug used?
Yeah, no, I have used mitomycin. I had actually a couple of slides on that, which I was going to show, but I wanted to stay within your 20 minutes as you requested. Mitomycin, the way we apply it is, first of all, it has to be constituted by our pharmacy. We are not allowed to do anything with chemotherapeutic agents. It's not like the way we apply it is that we locally apply it. So we have a small container in which the mitomycin solution diluted to the recommendations we want is poured. Then through the accessory channel of our scope, we pass a biopsy forceps. This is outside the patient. We have a cap attached to the scope. With the biopsy forceps, we catch a small, like 4 by 4 millimeter square tissue gauze. We soak it in the mitomycin. We pull it back into the cap. We take the scope into the patient and we touch it to the surface. We have to wear protective goggles. We have to make sure that we have got enough of gloves put on so that the chemotherapeutic agent doesn't touch us. And the pediatric literature has shown quite a bit of, again, promising results. I would somehow compare it to like what we have seen with steroids. The good ones get published, the bad ones don't. It has shown that this kind of topical application with all the chemotherapeutic prevention measures adapted during application as in children. I have not used it in adults, and in children we have used it quite a bit. I think most of the time.
So you apply.
Most of the time.
Do you apply it after the dilation or before the dilation?
I apply it after the dilation because I wanted to get into the raw tissue. Yeah, yes. It's the problem is this that how much of it will stay if you apply it before dilation and you don't shear the tissue and it is lying on the squamous epithelium or the fibrotic area, and then you do all your endoscopic work. You sometimes have to flush water to clean saliva and all. You'll just wash it away. So after you're done with everything, then I go ahead and then apply it. You have to, unfortunately, take the scope out if you're using a balloon through the scope. But if you use a bougie, your scope is already out. So when you re-intubate the patient to investigate after you use a bougie, you can always have the mitomycin ready. Yeah.
Thank you. I think my own experience is it could be quite useful in children with caustic strictures in Africa. So thank you for commenting. there's please, I encourage all of you to post your questions for Professor Dua, but there's a question here about stents, how long you leave them in follow-up. But I'd like to preface that question by saying many of us, stents aren't really an option. In our context, they're extremely expensive. They may not be available in the country even. And if they are available, they're generally not fully covered because they're more designed for cancer than for benign strictures. So I guess we do have some questions about stents. How long do you leave them? And I got the sense from your talk, you don't believe the stent alone is sufficient therapy. It's stent followed by dilations. I think that would be worth emphasizing. I guess another question is, if you don't have a stent, can you still do things like electroincision, or must you abandon any thought of that? You mentioned you always put a stent after that intervention. So a bunch of stent-related questions.
Yeah, now putting a stent after electrocautery incision is kind of my practice because I mean, I have been my fourth year fellows who are practicing keep talking about it, that I have been very aggressive with electrocautery. I mean, the thing is that it's a fibrotic area. Sometimes it's like an elastic band that you put in a stent, it stretches, and then you take the stent out, it just like an elastic band closes up. So when I cut very aggressively, and I'm pretty sure that at some spot or the other, I did perforate. Now, because of my aggressive approach on using electrocautery, I place a stent. It is not the standard of practice. When people use electrocautery, they don't place stents after that routinely. The other reason I place the stent is, like, if you imagine that you're cutting a piece of paper, you make a small cut in the piece of paper, and then when you stretch that paper, you tear it at the place where you cut it. It's like you're tearing a paper at the spot. So when you tear it, it is going to perforate. So once you do needle electrocautery and you have cut that area, now you want to tear it. If I use a balloon to tear it, I will definitely cause a perforation. So how about tearing it more with a stent, and at the same time it seals it? And in these cases, I don't put the stent in for more than 2 weeks because it's mostly more to seal a microperf and to tear and then pull it out. In other situations where we have strictures, where you have done what you have done, and the stricture is coming back 2 steps forward, 2 steps back, and what do you do now? The duration for which the stent is placed in is anybody's guess. I kind of keep it as a minimum of 4 weeks. My colleague over here has patients where he keeps it in for 2 weeks. It's interesting that if you're going to put a stent in and remove it, and when you remove it, you find that you put an 18 millimeter diameter stent, and the stent has stretched the stricture to 18 millimeters. You pull the stent out, it looks very beautiful, wide and open. And then you decide to bring the patient back in 12 weeks, which was the response to one of my questions. I can guarantee you that stricture would have come back by that time. It comes back with a vengeance, actually, if you pull the stent out and you don't do anything. So if you're going to, like in our protocol, start dilating the patients again on a weekly basis, and then if the weekly basis regression rate is not that frequent, for example, you with 18, you bring the patient back in 1 week and it has come down to 14, and you take the patient back to 18, you find that approach, then you can put the stent in only for 2 weeks. You don't have to put it for 8 weeks. So if you're going to use the stent only as a prolonged 24/7 dilator for 2 weeks and start the dilation protocol, again, my recommendation is that don't try to be 1 month, 4 months, or 3 months. And we are now increasingly noticing that because stents can cut both ways. It can cause severe chest pain. If it is across the GE junction, there can be reflux, it can migrate. So the shorter the interval you keep the stent in, the better it is. So if you're going to redilate them and go on the redilation protocol soon after you remove the stent, I don't mind even 2 weeks. Also, last but not the least, always keep in mind that any inflammation, like you're trying to put it in patients with corrosive injuries, and if there's active mucositis going on, you're trying to put it in patients with radiation injuries, and there is still active mucositis going on, it's a moving target. And when you put stents in a moving target, don't be surprised that an area of the esophagus above the stent can become tightly strictured, and now pulling the stent out becomes very difficult. So whenever I use stent, I make sure it's not a moving target. All the inflammation, whether it's from corrosive or radiation, has settled down, and then we think about stents.
So we've got one more comment here. We're close to the end of our time, but I'd really like to get your input on this case that one of our participants has posted. She says, from the few patients with caustic strictures who I've tried steroid injection on, I've discovered that they were developing some kind of frightening pouches around the strictures, which could imply reduced esophageal wall thickness due to inhibited fibrosis. I had to quit steroid injection because I thought I was increasing the chance of perforation on subsequent dilations. What is your comment on my experience?
Yeah, so that's an interesting observation that people have also. I mean, I talked about my cases who developed fistula, probably because the steroids reducing fibrosis doesn't let the microperforation heal. But these, what we are calling, are pseudodiverticulum. They are small pseudodiverticulum that develop. You share that area with a dilator. There may be areas that are not going to heal if you inject steroids, and they become small pouches. And the pseudodiverticulum probably is what I was mentioning about the fistulas, which is a precursor to that. I think you can still dilate them even if they develop the pseudodiverticulum. I have seen these also develop spontaneously in people who have tight strictures, and they develop proximal to the stricture, where there's a high intrabolus pressure that the patient develops with peristalsis, and they develop all these pseudodiverticulum, which is small areas between the muscle layers. So when you see them, it's not that they're going to increase the risk of perforation, but they really look a little bit alarming. And they're also a source of candidiasis. We sometimes see it developing in these patients. These pouches collect food. On the top of that, you have given steroids, and that could be contributing to the candidiasis.
Now, thank you, Prof. So I want to mention to all the attendees, we've put two links in the chat, one for feedback. Please take a moment to click on that and provide your feedback on today's session. And the other is a link to get a CEU certificate. We've started issuing certificates. If it would be helpful to you to have documentation of continuing education. So you can follow both of those links by turning to the chat. And while you're working on that, I want to ask you, Prof, another question about self-dilation. You said you didn't have time to tell us much about it. It was a fascinating video to see that patient who's clearly been helped by this. My question is, which patients are candidates? Would your typical patient with a malignant or caustic stricture be a candidate? And what kind of dilator do you give them?
Yeah, so very briefly, I think in our self-dilation clinic, we first take the patient to a fluoro room. The patient sits on a chair with the fluoro. The patient is watching the fluoro screen. We put a black mark on a dilator made of tungsten. It doesn't have any central hole. It's not like a guide wire driven dilator. It used to be that old Meloni dilators, where the tungsten makes it a little bit heavier. So patient is actually sitting in front of the fluoro screen. The mark we put on the dilator is the mark where the patient realizes that the dilator has now reached the level of the stricture. And after we first dilate the patient, say for example, we dilate the patient to 48 French or 51 French, that is 17 millimeters. 2 weeks later, not immediately, we bring the patient to the fluoro room and we give them a dilator which is 45 French, which is about smaller than what we took the patient up to. Under fluoro, the patient then watches how the dilator is going down while the patient himself is or herself is taking the dilator down, comes to know when the dilator has reached the stricture, takes it across, and this kind of biofeedback is done only once. We initially give them some viscous lidocaine to numb their throat, but over a period of time, they don't use it anymore. They just use some jelly. I have a patient whose wife dilates him every day. I mean, she learned the self-dilation part from the patient and started doing it on the patient. And it is amazing how the first reflexive reaction when you tell the patient that we are recommending self-dilation, the answer is no. We show them these videos, we take them to the fluoro room, and how quickly they learn. And I feel that especially in sub-Saharan Africa, if we can get some of these dilators from the company and give it to our patients, now once they don't need it, they bring it back and give it back to us. That this could be a very useful part of what you can do to these patients. And increasingly now, when do I offer this to the patients? I offer them when I'm dilating them on a weekly basis. Now I have come down to like once every 4 weeks to once every 6 weeks, and somewhere around about once every 6 to 8 weeks, I feel that that is the plateau for that patient. And I tell the patient, you know what, you are going to get yourself dilated every 2 months. Do you want to live with that, or should you just go in the morning, brush your teeth and put a dilator down? And this self-dilation is offered to them not at the end of the road. Anytime in the middle of the road, we offer it to them. And it's surprising how many people are taking it. They see 1 or 2 videos, they do it once. We also tell them, try it, doesn't work, don't do it. And they tried. I've yet to have a patient who tried it and later on said he doesn't want to do it. Because once they try it, their psyche is such that they realized that it is not as bad as they thought.
So tell us, would you do this with any benign stricture or only those that are fairly straight and symmetric? And what kind of dilator do you give them?
Yeah, so these patients should not have any pouch, like any pseudo diverticulum above the stricture, which sometimes our patients do develop. They have to be straight. Even if they are tortuous, it's not like they should be like in the form of a Z or a Z. They can still be a little bit tortuous, but the interesting thing is that, as I mentioned in those patients of self-dilations, the limited amounts that have been published, not a single one of them perforated. They stop. They are not under sedation. They're doing it themselves, and they are very quick to stop when they are hurting compared to when we dilate them in the room with sedation. So no pouch, definitely. A stricture that cannot be like a Z-shaped stricture, and a stricture that we were successful in dilating to a level, and they go 2 levels below that with a dilator. So we have 2 companies in USA. From the one is the one that makes the Meloni dilators, which no longer contain mercury anymore. They contain, it's a tungsten dilator. It's made heavy by tungsten. And the reason it is heavy is that we tell our patients that they shouldn't push it. They should extend their head and let gravity take the dilator down. But I have patients who are gently pushing it also down. Like you saw the patient I showed you, for video recording that patient, I gave him an American dilator that he pushed down, but that's not the dilator we give in. Now, our institute has problems. They do not want to give the dilators to the patients. I know Walgreen, which is one of our pharmacy companies over here, you could have given a prescription and they could go and get it from there if they want to, but that also the company is a little bit reluctant to do. So we get it for them and give it to them. And then we tell the patient that if you don't need it, or you stop dilating yourself for whatever reason, then bring it back and give it to us so that we can give it to some other patients.
Well, Prof, this has just been a fantastic session. We've all learned a lot from your rich experience and your innovation. And I'm sure that our attendees would love to be able to reference some of your materials. So if Prof does send us his lecture, we'll post it on our site. I encourage you again. Yes, thank you, Akwi. I agree, it was excellent. I'm sorry we didn't get to all of your questions, but thank you for asking them. And Again, please give us feedback, follow the feedback link, and there's a link there to if you'd like to get a continuing education certificate. Prof, thank you so much. We look forward to the next time you'll visit us at this clinic.
Yes, thank you very much. Yeah, it's been quite some time, and I really enjoyed my trips to, I think the last time I was there, end of 2017 or something, but this is really great. And what I'll do is that I'll send, do you want my talk sent over as a PowerPoint presentation, like I recorded just one, or I also have it on MP4 video, the whole talk.
Okay.
And I can send it
Beautiful.
over. My email address is at the beginning of my talk. So all the questions that I couldn't get to, if they want to email me those questions, I can even answer them via email.
Wow, that's a fantastic offer. Expert consult, world-class consult by email. Thank you so much.
Yeah. Thank you for having me. Yeah.
I'm sure we'll be taking you up on that. So thank you everyone for joining us today. This brings our session to a close.
Thank you.